Assalamu alaikum.
Walaikum salam. Yeah, welcome, Doctor. You can
Yeah,
start.
well, sorry for the delay. I've been trying to log in.
Okay.
Sorry. So, are we to start or we shall wait a
Yes,
little?
we can start. I think we can
Okay.
start.
Okay, thank you.
Okay.
Okay, please, are you seeing my screen?
Yes.
Okay, thank you so much. Okay. Okay. Good morning, everyone. My name is Sarah Umar Aliyu. I'm from Rashid Shakoni Federal Teaching Hospital, Jigawa State. I'm a pelvic and women's health physiotherapist. I'm here with you today to give some kind of presentation on female sexual dysfunction. Female sexual dysfunction is an area where most people are not well conversant with, or they don't even report the problem to the right people. So physiotherapists are among the people that manage female sexual dysfunction. So these are my synopsis. Let me take it to presentation mode. Yes. These are my synopsis. Okay. Introduction. Sexual function. Before we know the dysfunction, let's understand what is sexual function. Sexual function is it involves the integrity as well as synchronization of hormonal, muscular, and neurological system. If one of these is affected, sexual function might have a kind of issue somewhere. Female sexual function means normal physiological, psychological, as well as emotional process that aid women to experience sexual pleasure and satisfaction. That is what is meant by sexual function. So in any case where there is problem among the sexual response of a woman, the sexual response has 5 phases. There is desire phase, that is the wanting, that is the thinking that you want to have some kind of sexual encounter. Then the arousal state, that is when the body is more to the body response, when there is some kind of sexual stimulation. And there is plateau, that is when there is some kind of intense pleasure the body is feeling, and orgasm, that is when the body responds so intensively according to the pleasurable moment, and there is resolution when the body returns to its normal physiological state. Any dysfunction within or among one or others, it can be within the desire phase, it can be within the orgasm phase, it can be within the plateau phase, any phase that has a problem, that is what we refer to sexual function, the sexual dysfunction. And it occur when there is recurrent or persistent problem in any phase of the sexual response cycle. This can make the woman to be so debilitating and can affect her quality of life so seriously. Before we dip into what we know as the sexual dysfunction, let's understand some kind of response that occurs in different parts of the body when there is good sexual stimulation. Let's start with the brain, because the brain is the main organ that affects sexual response. Sexual response, usually it begins in the brain, because once you start thinking that you want to have some kind of sexual encounter, it's your brain that initiate that thinking. Or maybe you visualize something, or maybe you just perceive some kind of perfume that your brain will send some kind of trigger to the neural active to the brain, and the brain will trigger neural activation, which can lead to arousal, and subsequently, when there is sexual encounter, then it can lead to orgasm. In some people, especially male, even without sexual encounter, once the brain sends that signal and there is activation of that neural pathway, then they can easily go to orgasm. Unlike in female, it usually go hand in hand with sexual stimulation, which can either be personal stimulation or stimulation by your partner. Then the sensory signals that travel through the spinal cord and the cranial nerves to activate the brain areas, they are associated with emotion, pleasure, and motivation. A lot of areas in the brain are involved in sexual response. They include the hypothalamus, the medial insula, the cerebellum, the limbic system that is involved, the hippocampus, the hippocampus, and amygdala, and nucleus accumbens. All the brain area work together in order to give a kind of a pleasurable sensation to the body, and it's reduced. There are areas of the brain, that is the prefrontal cortex. There is less inhibition in order to focus the body on more pleasure rather than just critical thinking. There are some kind of hormones and neurotransmitters that influence sexuality. If there is some kind of problem among or within this kind of hormones, it can lead to any form of sexual dysfunction, like estrogen. Estrogen is a hormone secreted by female. It affects sexual response depending on when the woman is in her cycle, because during the follicular phase as well as during the ovulatory phase, the estrogen become so high in production. However, there is kind of dropping after ovulation. That is the luteal phase of the woman. Once there is kind of dropping of the estrogen, the woman will have less sensitivity to sexual encounter, but she may have more sexual pleasure during or around her ovulation. Then women that are lactating or undergoing menopause, they usually have decreased estrogen, and this affects their sexual life. There is what we call androgen. It triggers sexual desire and arousal. Its main action is to maintain sensitivity. Once there is some kind of touch or sexual stimulation, this androgen will help in maintaining that sensitivity by the body. And it stimulates the excretion of nitric oxide, which aid in clitoral arousal. The nitric oxide is also a kind of chemical that is secreted by the body that will aid in increasing more blood supply to the genital area for more pleasure. Then there is what we call oxytocin. It is secreted during romance to aid in suppressing vasopressin. Vasopressin is secreted when there is fear or when there is lack of connection between the partner, between you and your partner, while the oxytocin is produced or is created when there is kind of bonding. It enhances bonding, and it also includes more pleasure, which can lead to orgasmic contraction. There is, yes, I discussed regarding vasopressin, that is, it increases response to fear and stress. It offs sexual desire. It usually occur when there is no mutual understanding between the couples, or when there is kind of fear. This hormone is secreted and it will lead to off in sexual desire. The nitric oxide, as I said before, it promotes vasodilation, and it increases blood supply to genital areas. Once there is increase in blood supply to the genital areas, there is more sensation and more pleasure will be experienced by the female. Then there is what we call dopamine. It heightens the desire. It's created to help in heightening and maintaining the desire. It's a main pleasure neurotransmitter. Apart from the hormones, there are also some kind of areas in the body that a woman need to know, or the partner need to know, in order to be able to stimulate those areas for more sensation and for more memorable sexual encounter. There is what we call the clitoris. It is similar to male penis. It's measured around 3.5 to 4.5 inches long. And usually, once you open the genital area of a female, you cannot see the whole structure of the clitoris. You can only see the clitoral glands. That is some kind of a tip at the top of the vulvar region. That is the clitoral glands. You can only visualize that area, the clitoral glands, but the shaft, the bulb, and the crus are within the body structure. They are not visualized. They are within the body structure. They are covered by the bulbocavernosa muscle, and as well as the ischiocavernosa muscle, and by the labias at the top. That is, when you want to stimulate the clitoris, you have to stimulate those areas, the vulvar region, for more pleasure during sexual intercourse. It is the primary center for female sexual pleasure because it has a lot of nerve endings. And when there is a lot of nerve endings, once you stimulate or you strike the area, especially gentle stroke around that area, it will give a very sensitive play. It will give a very heightened sensation around that area for more pleasure. It is main function, as I said, is to produce intense sexual sensation and pleasure. Then, yes, this is the diagram of the clitoris. And outside, that is the exterior. You can just have a look of the clitoral glands. This is at the top. That is the only thing you can see. But interiorly, this is how it looks. It has the glands. It has the crus. The crus are the legs. So the legs are covered by the ischiocavernosa muscle, and it has the bulb, which are covered by the bulbocavernosa muscle. That is why it's very important to know how to stimulate those muscles while sexual activity. This is the bigger structure. This is how it looks. It's measured around 4 inches, and in some women it's smaller than that, around 3.5 inches. Another area is the vagina. The vagina is not the vaginal orifice inside the vagina. Inside the vagina, deeply is not sensitive. What is more sensitive in the vagina is the lower part of the vagina. Once you enter into the vagina around the first knuckle or the second knuckle, that is where the area is more sensitive due to the presence of the pelvic floor muscles. Then there is also nerve endings as well as the clitoris that is around that area. That is why it's very important to understand how to stimulate the lower part of the vagina during sexual encounter, not to concentrate about the deeper penetration. Then there is what we call the G-spot inside the vagina. It is located around 10 o'clock to 2 o'clock when you visualize the vagina as a clock. When you visualize it as the top is 12 o'clock, then the down as 6 o'clock, either of the side, one side for 3 o'clock and the other side for 6 o'clock. So when you visualize it around 10 o'clock going back to 2 o'clock, that is where you will find the more pleasurable sensation, that is the G-spot. And what make it more pleasure during sexual encounter once there is kind of penetration is the pelvic floor muscle grabs. Once the pelvic floor muscle grabs and contract in order to hold the penetrating object or the penetrating penis, that is when the pleasure become more intense. Yes, this is a beautiful picture of the vagina. This is the vaginal orifice. That is the opening of the vagina. Once you insert the pinker around 1 to 2 knuckle, that is where the pleasure is, and you located your G-spot. And this is the tube, the tube with different kind of ruggeds. And also this rugged, the presence of this rugged, the vaginal rugged is very important because once there is some kind of stimulation by an object or by the penis, that lining, the vaginal rugged, it also gives some kind of sensation to the penis and also to the woman. But this rugged will sometimes end up disappearing, especially during when the woman delivered more. That rugged will go, or when she is about to go into her menopause or into menopause, the rugged will also go because it's more dependent on collagen and estrogen. Also, into the sexually sensitive areas, we have the labia. That is the labia minora as well as the labia majora. They are so sensitive, the area are so sensitive due to presence of the clitoris beneath them. So it's good to learn how to stimulate those areas during sexual encounter. There is what we call the pelvic floor muscles. Healthy pelvic floor muscle will lead to pleasurable sexual activity. When the pelvic floor muscles are weak or they are tight, it will lead to sexual dysfunction. Like if the pelvic floor muscles are so weak, there is no way you can have the feeling of sensation because the muscles are weak, they cannot contract or they cannot compress the clitoris that will give some kind of pleasure. And if they are tight, they compress the muscles, they become spasm. They cannot even allow even a single finger to go around that area because it will lead to more severe pain. So healthy, it's very important to maintain a very healthy pelvic floor muscles for a pleasurable sexual activity. During sexual arousal, there is more increase in blood flow to that area. And the more blood to that area, the more the muscle will become engorged and the more will enlarge and give some kind of pleasure. Contraction of this pelvic floor muscle during the sexual activity, that is what will lead to orgasm. If these pelvic floor muscles are not contracting very well, they cannot initiate or they cannot go in, they cannot give that feeling of orgasm, that intense sexual feeling. You cannot have it. So it's very good for a woman to keep her pelvic floor muscles healthy. Then there is the breast or the nipples. Also, they are so sensitive, especially around the nipple area, around the areola, that is the darker side of the breast. A very good gentle stroke around that area will stimulate sexual arousal, and it will lead to more gushing of blood to that area and to the body in general. There are other sensitive areas like the back of the ears, the back of the neck, a lot of areas. The woman needs to experiment with herself to know which and where in her body are sensitive to touch during sexual intercourse and communicate it very well in a romantic way to her partner. So we are moving. Now we are into female sexual response cycle. Let's understand the response cycle. Once we understand the response cycle, how women go into different pieces of a sexual response cycle. There are 5 phases of sexual response cycle. The first one is the desire piece. That is the interest of sexual activity. Once it's just usually it's in mind. You start thinking, I want to have sexual intercourse. Or maybe you just speak with your boyfriend or your partner, and you just have some kind of feeling that you want to be with that person, or you just watch some kind of pornography, or you just smell some kind of perfumes that trigger some kind of sexual sensation in your body. That is what is desire. And it can last for many days. You can have the desire to have sex, or you can have a desire to have some cuddling, but you are not with the right person at that time, but the desire will remain in you for many days until you find the right person. And this, it depends on hormones. Just the way as I explained, it depends on hormones and the stage where the woman is in her menstrual cycle, and also depend on the partner. Are you desire to see that partner? No, I don't need the desire to see him. Once I see him, I feel like I'm off. Or is the environment okay for you to have that desire? Or do you have some kind of memory that you had some kind of encounter before with the right person you want, and you have that memory? They all depend on those factors. That is the desire piece. Then the arousal piece, to me, this is the most important piece, because for the desire piece, you keep thinking, you keep imagining, you keep yearning. But if the right person is not there, and your religion or your cultural situation doesn't allow you to have pleasure with yourself, so you keep yearning, you keep memorizing, you keep wishing, but it will not come. But however, arousal occurs when you are with the right person, or you are with yourself. You want to arouse yourself. That is response to sexual excitement. It can last from minutes to hours. It begins after erotic stimulation, some kind of touch, or some kind of visualization, or some kind of hugging, kissing, anything can trigger arousal. There is some kind of response the body will go once the woman is in this piece. The heart rate, the blood pressure will increase in response to that stimulation. Then the nipple, the labia, as well as the clitoris, they will enlarge due to increase in blood supply to that area. They will enlarge, they will enlarge and become more sensitive to touch. Then the hormone oxytocin and androgen will be secreted. The secretion of those hormones will increase, and vasopressin will decrease, because once oxytocin is in action, vasopressin will decrease. Then also blood flow to the tissues of the pelvic floor will increase. When the pelvic floor muscles are well nourished with blood, the vagina will expand, it will lengthen and swell in preparation to receive the receiving object, or the penis of the partner. Then there is what we call the battling glands. They are located just below the opening of the vagina. Those glands will also swell up, and they will start secreting some kind of lubricant that will stimulate the vagina, that will make the vagina more slippery. Then there is the plateau piece. The plateau piece, once the body is ready for that stimulation, all the factors that I mentioned are ready, and the woman is eager to have some kind of penetration. Her body is ready. There is some kind of heightened sensation at that time, but it's not the orgasm. There is just some kind of heightened sensation. The body will feel some kind of more pleasure and kind of wanting more. That is the plateau phase. It lasts for like 30 seconds to 3 minutes, depending on the body of the female. The lower part of the vagina will tighten, especially when there is some kind of object or the penis inside. It will tighten in order to accommodate the penis very well, and the upper part will dilate in order for the penis to penetrate deeper. So by that time, the uterus will shift above in order to give room for the penetrating object or for the penis. And at this time, it gives an intense pleasurable sensation. That is, the woman is about to go into orgasm after the plateau state. Then the next one is the orgasmic piece. This is the piece where there is a kind of feeling of relaxation or a kind of feeling of release. That is, during that plateau state, you tense, the body is so tense with pleasure, with everything, the body is high. And once there is that peak pleasurable sensation, the peak pleasurable sensation and a sudden release of that tension, that is what we call the orgasmic piece. And it lasts in some few seconds. In few seconds, the body will just relax and release the tension that it accommodates. It is at then when there is uncontrollable muscle contraction, just the way as I said before, if the pelvic floor muscles are so healthy, they will contract rhythmically, and they will make the body become more tense. They will make the pelvic area become more tense until you have some kind of that peak pleasure. Then it will suddenly drop. That is the orgasm. Some women experience some kind of squirting. Squirting is a kind of gushing of fluid from the urethra. Some they said it's from the vagina. However, many literature supported that it's from the urethra. It's some kind of fluid that is gushing out of the woman in response to that peak pleasurable sensation. Older women may experience orgasm better than younger women. So this is a place where many people, they don't agree, but according to literature, this is what the literature said. Older women, they experience more orgasm because the literature usually stated that the older women have been experimenting for long and they know where and what to do in order to give them that pleasurable sensation. Then the last phase in the female sexual response cycle is the resolution piece. It usually lasts in few seconds, about 5 to 15 seconds, where the body returns to its normal state. There is some kind of feeling of relaxation. There is some kind of feeling of satisfaction. The mind is very happy because it received what it wants, and the body will become so relaxed. The vaginal walls that are more tense, they will just collapse in order to let go of the object or the penis that is inside, and blood will gradually drain from the genital area. All this lasts for about 5 to 15 seconds. So this is the female sexual response cycle, from the desire to arousal to plateau to orgasm and resolution. So let's see the prevalence of female sexual dysfunction. The female sexual dysfunction is not usually reported because many women are shy and they feel it's not the right to report some kind of problem regarding sexuality. And this is also manifested in many cultures. Some cultures, they just take woman as a receiver because she just have to receive what she want, what she have, no matter how good or bad, she just have to receive it. However, in this modern society, women are being encouraged to report their problems to the right person. And we physiotherapists, the pelvic and women's health specialists, are the right channel to report such kind of problems. It occurs in about 43% of women. This is just in some kind of research that shows that. I believe it's more than that because I put it into myself. Whenever I'm in a gathering where there are women, I will just start talking regarding female sexual dysfunction. And before you know, if we are 10, about eight among us, they will have some 1 or 2 kind of female sexual dysfunction. So this is underreported. We need to move on and give some kind of of encouragement to our women to speak up, to say their mind, to report any kind of dysfunction for them to have that pleasure. That pleasure is what keeps the body, the mind, as well as the brain healthy. Low sexual desire is generally considered to be most common sexual dysfunction in women because once there is no desire, the almost all the sexual cycle will not even move. You don't have the desire for the sexual activity. Even if your partner touches you, you just have to give because you have to give because you are the receiver. You just have to give, but you are not having that feeling. You don't even have the desire for that activity. So more than half of women in a study of about 100 women, they have sexual arousal disorder. This is similar to the desire, but the disorder is even if there is some kind of stimulus, there is some kind of touch, there is some kind of visuals, there is some kind of memory. But if your mind is not on that activity, your body will not respond. So there is need for the woman to have some kind of good brain activity. Her brain has to be in order, has to be healthy for her to have good arousal because sexual stimulus start from the brain. Then about 63% of women reported arousal or orgasmic dysfunction. That is, the orgasmic dysfunction is common in many people because you might have the desire, your body will be aroused, you will have the feeling you are having intercourse with your partner, but at the end you will not have that intense effect that the people are saying, and you even heard someone saying, once I have that intense effect, I usually have even squatting, but you don't have that problem. So you have to check your pelvic floor muscle. Usually they are the one because the brain is working. There is desire, the body is responding, and the orgasmic dysfunction, you don't have that the pleasurable sensation and release of tension. So probably you need to check your pelvic floor muscle. Studies on arousals are difficult to predict just the way as I said, because you may have the desire, but the body is not responding. You have the desire to have sex. You have the desire to have some kind of cuddling, but the partner you are is not the right person. So what to do? What can you do? You have the desire, you want to have some kind of rest, you want to have some kind of pleasure, but your partner is not the right match for you, for him to stimulate you and go into arousal piece. Okay, the female sexual dysfunction is classified. This is the classification of female sexual dysfunction. So we are moving into the dysfunction. It's classified into some kind of categories based on the Diagnostic and Statistical Manual of Mental Disorders, that's DSM-5. This is the best classification that is in use now, the DSM-5. Among the classification is female sexual interest/arousal disorder. They think that interest goes with arousal. So that is why they merge it together and see there is lack of desire for that pleasure that you want. Usually, this problem occur due to biomedical some kind of sexual activity. Then for the sexual arousal disorder, recurrent inability to sustain or maintain sufficient lubrication or swelling response. What I mean here is you may have the desire, but your body is not responding to the arousal state. Your body, you may have some kind of lubrication at the beginning, but within some minutes, you become dry. In some people, they don't even have the lubrication. There is some kind of vaginal dryness, and the blood flow to that area is also minimal. That will enhance the swelling or the engorgement of those muscles or the soft tissue that are there for the pleasure to occur. Then the next in the classification is female orgasm disorder. Female orgasm disorder refers to absence, delay, infrequent, or reduced sexual pleasure intensity. That is, you don't even have, for the absence means you don't even have that intense tension in your body during the sexual encounter. You don't even have the pleasure, or it can be delayed. Some may don't have it, but later they will have some kind of the intense pleasurable sensation. But later, maybe before finishing the sexual activity, they may experience it for just some kind of seconds, and it will just vanish. However, in some women, it can be infrequent. In this sexual encounter, for today, you have the orgasm. However, for tomorrow, next tomorrow, you don't have the orgasm. That is what referred to infrequent. Or there is reduced sexual pleasure intensity. You may be having it, but the intensity that you used to have before is not the way you are having it now. So in this case, you need to check why there is absence of the orgasm. Is it that the brain is not sending the right in this kind, there is some kind of the pelvic area, there is kind of pain, or there is pain with penetration. This kind of pain will have fear, or the woman will have fear, or she will be so anxious that she doesn't want to have some kind of sexual encounter because she is fearing that she may have pain. Or there is pain. It's not that there is fear, there is pain. Once there is penetration into the vagina, that is the dyspareunia, that is painful intercourse. The object can penetrate, or the penis can penetrate into the vagina. However, once there is the penetration inside, then the muscle will go into spasm, and there is a severe pain that will not allow you to continue the sexual activity. Or there is vaginismus, that is, it will not even allow you to touch the vaginal orifice. The vaginal orifice are into spasm. Even a finger cannot go into the vagina because of intense pain. Then in the classification based on the DSM again, there is substance or medication-induced sexual dysfunction. This usually occurs in a situation when you are taking some certain drugs, maybe hypertensive drugs, maybe diabetic drugs. They can induce some kind of sexual dysfunction that may lead to low libido, that is low desire. Or you are taking some kind of alcohol or tobacco. Once you are taking alcohol or tobacco, it will reduce the sensation, the pleasurable sensation the body receives due to presence of that nicotine in it, especially the tobacco, because the nicotine is suppress the effect of nitric oxide that will give that pleasurable sensation around the endothelial cells or around the nerve endings. So what causes the female sexual dysfunction? There are a lot of things that causes female sexual dysfunction. If we can go with the classification, there are a different kind of classification, and each can lead to female sexual dysfunction. So according to this classification, they divide it into predisposing factors, precipitating factors, and maintaining factors. And the predisposing factors are factors prior to life experience, maybe before even you even start experiencing any sexual encounter. There is some kind of childhood sexual trauma, maybe when there is kind of rape or when there is kind of trauma that will result to the sexual dysfunction. It will lead to fear of even going into the sexual activity, or there is some kind of inherited factors like diabetes, because it was found that diabetes can lead to reduction in libido and even the diabetic drugs. There are the precipitating factors, or we can name them as triggers, maybe stress. The stress can come from many things. Maybe it's the stress from work, stress from financial issue, stress from the family issue. All this can contribute to that, because once you are in this stress, your mind is not even focused to understand or for the brain to be able to send the right signal to the right channel. And also there are some kind of medication, just the way as I said, some kind of medication can also lead to low libido. There are some kind of maintaining factors. They said these factors are ongoing life circumstances. They can be lack of privacy, because you can have everything. You can, if you are in the right place, you can experience the desire, the arousal, and even the orgasm. However, if you are in a wrong place, for instance, in a house where you live with your partner and your in-laws are there, and the room you are so close that even your in-laws can hear some kind of sexual sounds, you may not even be comfortable to have that series of sexual activity. You may not be comfortable to have that series of sexual activity. So in this case, the right place, right environment need to be focused for sexual activity. You just don't have to have sexual intercourse, especially female. For male, they can have intercourse anywhere, provided they have the urge. However, for a female, they need to have some kind of privacy for them to be relaxed and initiate the sexual activity. Also, there is what is called performance anxiety. For you are anxious, you want to perform better. However, by that anxiousness, you are not concentrating on your body, you are not concentrating on your mind, you are not relaxing your mind to experience the pleasure your partner is giving to you. You are just eager to give something that maybe your body is not even giving. You want to be the best in sexual encounter. So you are eager, you want to have that kind of performance better. So it will lead to anxiety, and at the end, you lack everything. You cannot even perform very well. However, this is more in male because they usually want to give the best. So by trying to give the best, they end up not giving anything. Thank you. Okay. Then there is some kind of another classification. They classify it based on biopsychosocial model or biological or medical cause like hormonal imbalance that is accompanying menopause, or it's accompanying lactation, or due to some kind of chronic illness, or substance or medication-induced sexual dysfunction, just the way as I explained before. The other classification, they classify it based on the predisposing, precipitating, and maintaining factors. But this, they take it into biopsychosocial model. So for the psychosocial cause, example, depression, anxiety, negative body image, or past trauma. In this, the negative body image usually occur in female because she may see herself not very beautiful, because she may be hiding her body. She will not be relaxed to have the sexual encounter freely. She may feel her body is lax or her breasts are are down, or she is obese. All this negative body image, we have to stop it. You need to appreciate yourself. You need to work on yourself if you want to look better. You need to exercise. You need to take some kind of supplement for your body to be the way you want. However, it's not a crime for your body the way it is, especially if you give birth to enough of children. You cannot expect your breast to stand. So your breast has to collapse, and you have to appreciate yourself, and your partner need to appreciate you because you give birth to his children. Then there is also some person social context, example, poor communication. This is so very common. There is lack of good communication between partners, and this can lead to a lot of sexual dysfunction and inequality in relationship. Because if there is inequality in relationship, the male may feel they are superior in terms of sexual encounter. No, there must be some kind of equal activity. You give and I receive, but the way you give will be the way that I receive. Give good, then you will receive good. That's what will be the equalization. Just the way as I explained before, there is need for privacy. Also, there is need for cultural and religious restriction. They also need to be taken care of, especially in a people that are more concerned regarding cultural and religious restrictions. These are general etiology, just the way as I explained, irrespective of where they belong, there can be some kind of relationship issue between the partners, because if there is no good relation between the partners, it can lead to different sexual problem, and you cannot even have the feeling to initiate sexual activity with the partner. When the pelvic floor muscle has some kind of dysfunction, either hypotonus or hypertonus, then it can lead to also a problem. When you have some kind of multiple sex partners can lead to a lot of dysfunction, because you may end up having infection, and once there is infection affect the sexual function, affect the way your pelvic floor muscle work, and your body in general. There is what the body image, or there is kind of self-esteem. Then pregnancy and childhood, they also lead to that. Then the breastfeeding, menopause, just the way as I said before, due to decrease in estrogen level. Then there is kind of stress, or there is fatigue within the family, within yourself, then they can all lead to sexual problem. History of sexual abuse, medical or psychological condition can all trigger female sexual dysfunction. So female sexual dysfunction can be presented in different ways, depending on what the problem is, where the problem is. For instance, the female can present with chronic pelvic pain. The chronic pelvic pain can be due to a lot of things: vaginismus, dyspareunia, anything around that area. Maybe that is a kind of a presentation of FSD, because once there is pain, there is no relaxation that will ensure good sexual encounter. Then there is vaginal laxity, that is vaginal weakness. Once the vagina or the pelvic floor muscle in general are weak, the vagina will not hold firmly the receiving object or the penis, and that will lead to lack of proper or enough sensation that will lead to orgasm. Then there is vaginal dryness. The vaginal dryness can be due to lack of enough blood supply to that area that will aid the Bartholin glands to secrete some kind of lubricants. And this will lead to painful intercourse, because once there is a penetration and there is no some kind of good lubrication, it will lead to kind of bruises around or inside the vagina, and it will lead to pain, and subsequently the woman might even reject the sexual activity. Then there is pain before or during penetration, which can be due to vaginismus or due to dyspareunia. There is lack of pleasurable sensation during intercourse, and this lack of pleasurable sensation can be due to lack of that vaginal ergonomics or due to lack of concentration in the sexual activity. The female need to concentrate herself, that she need to put herself, her mind into the activity and put her mind that she want to receive the pleasure, not to be eager to satisfy her partner, because that is the more focus of female. She's not focused on herself. She is eager on how to satisfy her partner. She may even fake orgasm. She may be screaming, but that screaming is a lie. She is not feeling anything. So she need to focus on herself, on having that sensation to her to her body. However, lack of the pleasure can be due to aging when the vaginal ergonomics start to disappear and there is no good pressure or good friction within the vagina during the sexual intercourse. Then there is inability or decreased ability to reach orgasm. All these are kind of the presentation that women present when she have the sexual dysfunction. Sexual dysfunction affects women so severely. It goes beyond the bedroom, not just that she cannot have not just that she cannot feel the pleasure, not that she cannot have the orgasm, or that she cannot even satisfy her husband. No, it affects the woman beyond that. It affects her physically, psychologically, emotionally, and generally. Her overall quality of life is affected. Many women, they describe feeling of being broken. Once you start talking to a woman sometimes regarding sexuality, she may even break into tears because she is not into her mind. At that stage, you may see the woman is into depression, and you need to work towards that and even refer her to the right channel. There is poor mental health, yes, then vaginal dryness and painful penetration. Despite the dryness and the pain in penetration, some women, they will endure the pain in order to give satisfaction to their partners. This must be stopped because you are injuring your mind, you are injuring your body. Your partner needs to know that you are not feeling the pleasure, you are into pain. So he has to help you in achieving the right thing during sexual intercourse. So these are all the preambles we have been saying. At least we have some kind of understanding regarding female sexual dysfunction. Before we go into the assessment, do you have some kind of question, clarification, contribution? So that once we are into the assessment, you may have some kind of clear explanation, some kind of clear understanding about how to assess the female sexual dysfunction. Anyone with any contribution or question, or we can move on? Thank you. Hello.
Good morning, ma. The presentation has been really self-explanatory. So you went into details on each of the items. So I don't have a question for me.
Thank you. You're welcome. So we can move on?
Yes, we can.
Okay, thank you.
Yes.
So we are into assessment of the pelvic floor. No, sorry, the female sexual dysfunction, sorry. So the first thing in assessing the FSD is proper history taking, because without proper history taking, you cannot ascertain what is wrong with that woman. That woman you need to encourage the woman to open up. You cannot just say, okay, tell me what is wrong with you. Well, no, if she come with that complaint, make her relax, make her feel you are part of her problem, make her understand that you are an expert in that area, that you treat more people related to her problem, and you are here also to help her in solving her problem. Make her feel so comfortable with you so that she can open up for you to understand what is really her problem, because you cannot channel the problem. You cannot plan your management without proper understanding of the female condition. So that is why I said patient interview. It will be like kind of interview. You ask her many questions, you give some kind of prompt and let her speak. You ask her even regarding her partner. Let her speak regarding her partner. Give her more time. You don't have to say you have to finish everything within some minutes. No. You need time to give the patient, to give the female enough time for her to open up for you to understand what is really the problem. For instance, if the woman said, my chief complaint is, I don't feel anything during intercourse. So I don't feel anything. You ask her, for how long? That is the timeline of the problem. How long? Since when? She can open up and tell you, maybe since when I'm married. You can tell. There is a woman that I met. She's old enough, around 45 years. She said for her marriage, for 25 years of her marriage, she's not feeling anything. She's just given what is destined for her according to her religion, that she has to open up for her man, for that is all, but she's not feeling anything. So this is very serious. For 25 years, you are with a partner and you are not feeling anything. This is so serious. So you know the timeline. Then you ask her regarding what contribute to her problem, the contributing factors, what contribute to her problems. Maybe she may open up that since when I started taking some kind of medication, I was diagnosed with diabetes. And since when I started taking some kind of medication, that is when I observe I have so problem. So from there, you can know that the problem is due to medical issue that is part of the biomedical model. Then, no, she might say, since when I changed my partner, my boyfriend before is giving me the sensation I want, but this new boyfriend that I have is not giving me what I want. So you can know that it's not her fault, it's the relationship problem, is the man that is not doing the right thing. So you keep questioning, you keep asking regarding the contributing factors, whatever is contributing to the woman, you keep jotting, and at the end you analyze. Then you ask her, by asking, you ask her, is it lifelong or is acquired? Just the way that I said, she said before, I have the desire, I have the arousal, I even reach orgasm, but now I suddenly don't feel anything. You ask her why. Did she have some kind of a problem now? Maybe hypertension. Before she was not hypertensive, now she was diagnosed with hypertension. No, maybe she has some kind of stress in her family. There is a woman that she delivered a child with cerebral palsy. Since when she started taking care of that child, due to that stress in her mind, she said she doesn't even like to be with her husband because she doesn't even want to initiate sex. She's afraid of giving birth to another child similar to that baby. That means her body is still intact, but her mind is not there. Or that means she acquired the problem in sometimes in her life. It's not lifelong. It's not since when she started having sexual encounters. All keep documenting all those things. Then you ask her if it's generalized or situational. What I mean is generalized is, let's say the woman is having different sexual partners. So she said she's not having good lubrication. So does that, you ask her, since you said we're having different sexual partners, does it apply to every partner? You don't have that lubrication? She said yes. So that means that it's from her. But if she said no, that is so of the situational issue. She may have the good lubrication with this partner, but the other partner, she doesn't have the good lubrication. That means it's the problem of the relationship. She's not even comfortable with that person, or the person is not touching or is not doing the right stimulation that will give her the pleasure. Then it can be also, as I said, generalized also. It can come in under the context that since when she married, in a situation where the woman is not having more sexual partners, this will be difficult to quantify. However, since when she married, she is like that. That is a generalized, is a love-like issue. However, if it can be situational, or the generalized, I mean, she can have the desire, she can have the arousal, the body will respond. However, suddenly she end up being dry. That means it's situational, usually occurs when there is interplateau piece. She have the desire, she have the arousal, but suddenly the body response will just go and I will be dry. That is so of the situational issue. That is for a partner that doesn't have many partners that you can have that quantification. Then you can also check for the severity. Maybe she said she's having so much pain. Is the pain mild, moderate, or severe? You can ascertain the type of pain using the BAS, the visual analog scale. You can have the quantification of the pain, or how does the pain occur? Is it so severe that it will stop you from the encounter, or is it mild that you bear and continue with the encounter? Also, you assess for any body changes. You check the vulvar area. You ask her regarding any changes in her vulvar area. Does she have some kind of bruises? Does she have some kind of polyps, or there is some kind of atrophy in the vulvar region? Or is she having some kind of condition that she may be thinking is leading to her the problem? In this context, the patient need to have more time, and you need to be open and have a good, effective communication with the patient so that she can open up with you and also said what is in her mind. Also, you ask her regarding her partner. Is her partner okay with her, or she is just managing? Keep asking her until you know the right problem. However, if she is with the partner, try and understand how to give some kind of cues, because you may end up worsening the situation instead of giving the solution. Because if you say, are you okay with the partner? And she said no, and in front of that person, do you think you are doing the right thing? No. So you need to have some kind of manipulative questions for you to extract more information from the couples. Then, according to the DSM-5, that's the Diagnostic and Statistical Manual of Mental Disorders criteria, she said you cannot say a female have some kind of sexual dysfunction unless she fulfill these 4 categories. The duration, that is for at least 6 months. She have that problem for at least 6 months, according to them. But according to some researches, I cannot write anything in the slide, I'm sorry, because it's so bulky. But according to some researches, they said this is not applied because there was a research that was conducted in Ethiopia. They said they applied this rule of the SM5 for at least six months, and they just end up with like 5 or 10 participants. However, when they make it open, do you have some kind of problem? Before you know it, a lot of people are into that study, because I may have the problem, maybe it just for kind of 1 to 2 months that I have the problem. How can I wait until 6 months if I know what I'm doing? I know what I'm doing, and especially how can I just let that I don't feel anything with my partner and let it until it reaches 6 months? So depends on what you as a clinician take and what the patient wants. Then the frequency, that is the symptoms occurring in 75 to 100% of sexual encounter. If you have the symptoms, they said the symptoms have to be in about 75 to 100% of your sexual encounter. Maybe you have been having some kind of sexual activity, but today is okay, but tomorrow is not okay. Today is okay, but tomorrow is not okay. That is around 50-50. So you are not qualified to have female sexual dysfunction according to the DSM-5. It has to be about 75 to 100% in all your sexual encounters. So also this also has a problem in some research, and they denied this classification. Also, there is some kind of distress. You have to rule out some kind of distress that is causing the problem. Symptoms causing clinically significant distress. Anything that is causing the distress, you have to rule it out before you say she has the the sexual dysfunction. Like for instance, she's having some kind of financial issue, and for the past 1 year, the woman is not into her mind. She just have to go into sexual activity with her partner just for the sake he's my partner. But she's not feeling anything because she is into kind of distress that will not even allow her mind to rest and receive the sexual pleasure. So you have to rule out that distress. So in this context also, if you rule out that distress, but that woman reach like 1 year, so she's qualified regarding the duration, that she's more than 6 months. So will you say she had the pelvic floor dysfunction or no? So this is another person in this category. Then not better explained by medical condition like depression, substance use, or medication. Once you rule out the patient has depression, she is into alcoholism, she's taking a lot of tobacco, or she is taking some medication that have been proven to lead to low libido or that decreased sexual sensation, she is not even qualified to be called for that she has female sexual dysfunction. So whatever the clinician need to take, she can take it, but this is what in the literature, based on the DSM-5 classification. Then you need to assess the pelvic floor muscles. The integrity of the pelvic floor muscle can be assessed either externally or not only the pelvic floor muscle, the pelvic floor in general. You need to externally assess it and internally assess it also. For instance, you can ask the woman to uncover herself. Before that, you tell her that you want to assess her pelvic floor. However, she needs to undress herself. She needs to lie and make the place more visualized for me to see if there is any problem outside. And if I check there is no anything outside and I have to go inside and check, I have to go inside. Let her know. Make the patient comfortable. Ask for her consent. Also ask for her if she needs anybody around, especially if you are a male therapist. Ask her if she needs anybody around. And for you as a therapist, you need to have someone that will assist you in delivering the assessment, because you need to put a clean gloves, you need to have some kind of lubricant. You cannot be the one taking the gloves, opening the lubrication jar, pressing it, everything. You may end up contaminating your hands. And at the end, you place your hands in her vagina or somewhere around the vulvar region. So you need to have some kind of partner that will assist you with that. Also, let her know that this is my partner. He want to assist me in order not to transfer some kind of infection into you. Keep explaining to that patient. Make her feel comfortable with you before you initiate the pelvic floor assessment. Then once she is lying on the bed, make her rest. Tell her when you are ready for me to start, just tell me. You cannot just say, lie down, up, and then you start doing. No, let her be comfortable. Let her rest for some 1 to 2 seconds. And before you initiate it, try and place your hand around her tummy or around her legs for her to feel your touch first before feeling the touch around the private area. Let her be comfortable with your touch. Talk to her. I want to start. I will start with the outer part. Then later I will go in if there is no any restriction. Once she signed consent and she's okay, then you start. You ask her to lie down, to open her private area. She flexes her hip and her legs and widely open. The place has to be well lit so that you can visualize everything, and it must have some kind of privacy, not just for someone to bang in while you are assessing her privacy. No, the place has to be so secured for her, and you tell her the place is secured. You can see I close the door, no one will back in. It's only me, you, and my assistants, or with your partner, depends on what she wants. So once you start, you give some kind of gentle touch around the vulvar area, from the mons pubis to the labias to the areas around the vestibule. You give a kind of touch, you observe the area, you keep a kind of light touch and see if there is any pain, if there is any restriction that will prevent you from going in. The restriction that will prevent you from going in is like infection. You visualize the area, the area is so bushy, is so smelly, and there is some kind of discharge that you are thinking might be due to infection. You don't have to go in. You ask her, so for now we are stopping here. Don't tell her that she's bushy, she's having infection. No. Tell her that you are stopping here for now. Then in our next appointment, we are going to do the internal assessment. Before the internal assessment, I want you to use like 3 to 5 days from now. Go and be washing yourself with warm water and a little salt. You have to shape the area. You have to teach her some kind of good hygiene that will help clean that area before you proceed. So if she is good to go and she's okay, you can continue with the internal pelvic floor assessment. Then you change a glove. It's good to change the glove because you touch all that area, you remove that glove, you change another glove, and now you are going to use some kind of lubricant. You ask the partner to press some kind of lubricant in your finger. Then you gradually rub around the vaginal opening for her to start the feeling, not just put it inside. No, you start with one finger. Then if there is need for another finger, you can inside the 2 fingers, but you start with 1 finger at the beginning. Once you put the lubricant, you place it around the vagina and gradually mobilize the area around the vagina for her to be comfortable with your touch. Ask her, is there pain? No pain, no pain. Gradually, you insert your finger. Once you insert your finger, you leave the finger inside for her to know or to be comfortable before you start the touching within. Then once she is comfortable, you keep giving her some kind of cues. You keep talking to her so that she can be okay. I want to touch different angles in your vagina. There is what we call the upper part, the side part, and the lower part. Use the simple English you will understand. Don't start saying there is pubic symphysis here, there is coccyx here. No, use simple term that she will be comfortable with. You start from the pubic area, the pubic symphysis area, that is around the 12 o'clock. You visualize you visualize a clock around that area. You start from 12. You ask her, I want to start from here. Are you feeling some kind of pain? Wherever you reach 1 o'clock, is there pain? 2 o'clock, 3 o'clock, up to 6 o'clock. Then you move on and back to 12 o'clock. You ask her if there is any kind of pain within that area. While asking her if there is pain, you also have the kind of feeling. Is the muscle so good? The texture of the muscle, the tonicity of the muscle, is it good or what? Or there is some kind of asymmetry. At this side, I feel the muscles have good tone, but this side, I feel there is some kind of weakness or something. You keep noting whatever you have, or you keep telling your assistant to note what you are saying, because you might forget, or if you are a kind of guru that you assimilate everything, then later you can document whatever you experience within the vagina. Also, you check for any kind of lumps, asymmetry within the vagina. And once you finish, then you can remove the finger and ask her, you are okay, thank you for allowing you to do that assessment. However, there are situations that once you put a finger and you ask the woman, are you feeling my finger inside? She said no. And you start touching the walls and you see the walls are far away. That means there is some kind of laxity, or the vaginal opening is so big, you have to insert another finger. So you use 2 fingers inside for more sensitive, no, for more touching, for more kind of feeling that you will be feeling. You insert 2 fingers inside the vagina to have a good kind of sensation there. Then you do the assessment as I explained. Then you later remove your fingers, you wash your hands, and you continue with your other assessment. That is for the external and internal pelvic floor assessment. After the assessment, you record muscle contraction. Sorry, I forgot. Once you are inside, you need to assess for the contraction and relaxation of the muscle as well as the endurance. You ask the woman, are you feeling my hand? If it is one finger, you document it's one finger. If it is two fingers, you document it's two fingers. You ask her to contract. Is the contraction weak or is even not there? That is absent, or there is the contraction is normal. You feel the squeeze and lift of the muscles so that your finger is squeezed and it's lift up. That is a good contraction. Or you ask her, can you hold the contraction for like some seconds? Once she contract, she release. That means the endurance is so for. Or she contract for like 3, 4, 5 seconds, 6 seconds, then she release. That means the contraction is moderate. Or she have a good contraction. You can even count up to 10 seconds with that strong contraction in your fingers. That means the endurance is so excellent. And for relaxation, you ask the woman once she contract the muscles, you ask her relax. You feel, but she's not relaxing. Your muscles are, your hands are still contracted with that muscle. Ask her relax. Maybe she completely relax and let go of your hands. That means there is complete relaxation. But you ask her relax, relax, relax. Let go of my hand. She didn't do it at the beginning, but later she do it. That is, there is delay in relaxation. Or at all, she couldn't even relax herself. She continued to contract your fingers. That means there is absent a relaxation in this woman. So in this case, you can quantify what is exactly the problem in that woman. Is there a problem with the contraction? That is, there is hypertonicity, or there is problem with that there is the problem with the relaxation that she cannot even know. Sorry, there is the problem with relaxation. That is, there is hypertonicity, or the tone is normal, or there is hypo. She cannot have a good grasp of your hands. That is the hypertonicity. So you need to document everything. Once, if you use one finger, you write you use one finger. If you use two fingers, you write you use two fingers, as well as the kind of position you assume. Maybe you insert one finger and do the right side of the assessment. Then maybe you cannot move your finger in the clockwise or anti-clockwise movement. So you have to remove the finger and use the other finger for better assessment. So this is the imagery clock that I have been talking. You start with the 12 o'clock, that is around the pubic area. Then gradually you continue from 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock, up to 6 o'clock. If we are okay, you can move your finger to the other side. That's better. If you cannot, don't stress yourself, remove your finger, then you can use another glove and do the other side with different finger. There are different outcome measures that we can use. However, I didn't put many outcome measures. There are kind of outcome measures that you can use to assess many things, like the visual analog scale. You can assess the pin based on 1 to 10 grids. 0 to 10, 0, no pin, and 10 higher pin. Then there is perfect scale. The perfect scale means P stand for power, E stand for the endurance, that is the ability to hold the contraction, and R stand for repetition, that is number of repetition of hold the woman can hold. Then there is F, that is fast movement. How fast can she move? Contract and release, and every contraction time, that is the ECT scale. That is the perfect scale. However, for you to have the power, to know the power, you have to use some kind of other scales, like the muscle grading scale, or the the contraction scale, the digital pelvic floor contraction scale. Here is the digital pelvic floor contraction scale that I wrote. There are many contraction scale. You can even use our normal one that we have been using, the Oxford grading scale that we have been using, or we can use this one, that is the digital pelvic floor contraction scale. When it's 1, when there is poor pelvic floor muscle, that is, there is mild or no hold in your fingers. You don't even feel any hold, any kind of flicker, or there is very mild flicker of movement. That is the pelvic floor muscle. You can say there is poor pelvic floor muscle contraction. Or you can feel some kind of hold, or but the hold is not from every wall. Once you insert your finger into the vagina, the wall, if the pelvic floor muscles are working rhythmically and at the same time, you will feel the contraction from different angles. But once the pelvic floor muscle is weak, there is no circumferential hold. That is, you will feel the hold maybe from one side and the other side is not even moving. So that is 2 o'clock. Then there is voluntarily active pelvic floor muscle. There is a circumferential hold and the muscle are tight. You feel the tightness in your hand. That is the 3 o'clock. That is the 3. Then 4 plus, that is voluntarily functional pelvic floor muscle. There is complete hold, and there is, you will feel, once there is hold, not just the hold, you will feel a kind of upward pull with conscious effort. The female has the effort. She is doing it with so much consciousness that she is pulling the hand up. That is 4. And in 5, that is, there is involuntarily functional pelvic floor muscle. There is a complete circumferential hold with upward pull against resistance without conscious effort. Even without putting more sense into the pelvic floor muscle, you can just have the grasp of the hand and pull it up, and you can even do it in different position, whether in sitting, in lying, or in any position. That is for the contraction scale. And there is one for the relaxation scale. That is, yes, for the relaxation scale. I forgot to write it because I have some kind of constraint, but it's just for the relaxation, the ability for the muscle to relax. That is, if the muscle cannot even initiate relaxation, the patient continue to hold your hands. That is, there is lack of relaxation at all. There is absence of relaxation, or you feel a kind of relaxing, but it's not fully relaxing. That is, there is kind of not completely relaxing. That is, the muscles are not completely relaxing. Or there is complete relaxation from different angles. You feel the muscles are relaxed. That is complete relaxation. Then there is the female sexual function index. This is an instrument that is commonly used in order to quantify sexual function in female. And it has like 19 items scale. It has different domains. It has the domains of satisfaction, desire, arousal, orgasm, and pain. And each domain has its on finding. You can have a good finding in satisfaction, but you don't have good finding in orgasm. You can be satisfied, but you don't have the orgasm. Depends on the patient discretion. She said she's okay with her partner, but she doesn't go to orgasm. She's having pain. However, despite the pain, she feels satisfied. All these are parts that can be quantified. So after the assessment, you record everything and you set up your goal. You discuss the assessment with your patient. You tell her this is what and what that I observe you have the problem in. The goal of the management will depend on the outcome of the assessment. However, the main goal is to restore mutual sexual comfort and satisfaction. That is the main goal of treating female sexual dysfunction. However, there are some kind of specific goals depending on what the patient present. One patient will say, I need pain relief. Someone will say, I want to improve you might find out from the assessment that what the patient needs is just some kind of pain relief. When she has the relief from her vaginismus, she is good to go. oh, this patient, we need to work on her pelvic floor muscle function. The pelvic floor muscles are so loose that we need to rehabilitate, or they are so tight that we need to relax them. Or what the patient is have is just to improve sexual pleasure. Let her examine by herself where and where does she have some kind of feelings or some kind of sensitivity once she's touched. But there are some culture or religion that stops that. So you need to focus on your partner. If he's touching you, where do you feel more pleasure while he touch? So you can communicate very well with your partner where you may need to be touched more. However, you have to avoid certain goals that may worsen the patient condition. The goals is for you as the clinician, as also for the patient. You ask her goals, then you also tell her this is your goal based on your assessment. Like just saying your goal is to achieve orgasm. No, you tell her no. Your goal is to achieve pleasure. Don't concentrate on orgasm, because if you concentrate on orgasm, you will lose many pleasure. There are a lot of things to be witnessing before you go to orgasm. You tell her that once you are into, you have the desire, your body is responding very well, and your mind is there, you will go into orgasm. So don't concentrate on saying you want to achieve orgasm, because your mind is only focused on orgasm. You are not relaxed so that your body will receive the good sensation from your partner. You need to relax so that you can have the orgasm as a credit for your relaxation. So in the management also, you have to identify the cause and plan accordingly. What I mean, your assessment will guide you into knowing the cause, and you make your plan that this and this are your problem, and based on your problem, and because I treated many patients with that problem, and this is what I did to them, and they are okay. Convince your patient about your plan. Don't just say, this is my plan and we are going to work on it. No, convince your patient to accept the plan, because if she is not accepting the plan, you are not with her 24/7. She needs to go home, and you need to give space for her, maybe like some days, like 5 to 7 days at the beginning, for her to go and practicalize the plan or the treatment you described. You need to give time for her to go. If she's not okay with the plan, she will just go home and continue her life, and you will not see any change in her treatment. However, you have to refer a patient to the right specialist if there is need for that, to address any interfering problem. Like if the patient is having some kind of cardiovascular issues, or she is into diabetes and not good on medication, you need to refer her to the right person for him or her to see the patient and do the needful. You have just the way that I said, you have to discuss the plan with her if she's alone, or with the couples if the partner is available. However, you have to refrain from taking side. Avoid taking side while discussing an issue, because if you take the side of the female and you are putting the blame on the male, you are just rubbing salt to the wound, because he may be angry that she just come and report him. No, just talk with polite within polite way, talk with sense and avoid taking side. You can say, I understand your problem. Your problem is you have some problem with arousal. Your body is not responding well. So I thank God your partner is here. He's the one that will walk you through that process. Maybe she told you that he's not doing anything. He just come once he's urged, he just come to her, open, make her continue. That's many women, they receive that kind of issue from male. But you just say, thank God your problem is arousal issue. Your body is not responding. Your body is not getting ready before the penetration. So I thank God your partner is here. You please him. You talk to him. You press him. So, Oga, you are here. The main work is you. I'm just a guide. So you need to do some kind of things that will make her body ready. You need to experiment. You need to know where to touch so that her body will become ready. And you need to give more ample time for her to be ready before you proceed. I'm just guiding. You are the doctor now. Just press him. Give him the credit. So you know how our men are. They want credit and they want the press. He will definitely work wonders in that area. Then also you have to communicate effectively. Communication here is for you to know how to talk to the woman. Tell her this is her problem. Maybe her problem is from herself. She's not even so attractive for the man to even initiate sexual activity. Don't tell her that you don't take bath, you do. No, teach her as a woman, you need to take care of yourself. You need to bath morning and evening. You need to keep washing the private area. Wash your private area with clean water. Once you are bushy there, try and do some trimming. But depends on how your man wanted. Someone wanted bald, some wanted with some kind of hair there, depending on what your man had wanted. You need to be washing your area, but don't use soap. Soap make you dry. Use clean water. And sometimes you use some kind of salt, the little salt in your water to clean your area. Use perfume. Don't let your man perceive any kind of odor from you. It will shun him away from you. Also, know how to talk with your man, communicate very well. Then you move on. The treatment session in this regard differs. It depends on the patient and it depends on the condition to be managed. There are some kind of condition that you cannot just go and start treating the patient. The patient need to go and see maybe her cardiologist. If she has some kind of cardiovascular issues, they all need to see her endocrinologist. And once she received medication regarding her underlying issue, then you watch, does that problem persisted? Then you continue with your own side. And also there are some women that may have a lot of problem. She present with vaginal dryness. She present with lack of sensation. She present with a lot of things. So you need to sit and see which are to start with. Maybe she has also some kind of relation problem. She has vaginal dryness. She's not feeling orgasm, and her husband is not doing anything. From the beginning, you don't just go say you have to start using lubricant. Lubricant will not work here because the problem is the partner. You start working with the partner. You ask her that you want to see her partner. If he is convinced that he'll come and meet you, thank God, then you know how to talk to the partner in a polite way, in a pressing way, and talk to him. If he doesn't want to come, you tell her, no problem, I can talk to him through the phone. You can talk to him through the phone. You press him, you ask him, you need to be there, okay? The problem, you are the problem solver of your wife and just a guide. Give him some kind of present. He will definitely come and meet you. So the sessions are not timed. It depends on the condition of the patient. So the main issue or the main management, these are all the preamble that you have to take. Those that I explained. So the main management, you start with education. You educate the woman regarding her anatomy, regarding the brain, regarding the brain response, regarding the body response to sexuality, and also regarding her hygiene. You also counsel her on any issue that she may have. You tell her that she is not the only one into that problem. Tell her that many people have such kind of problem. If you have many people with such kind of problem, keep grouping them together and have them have a common group that they can be discussing their problem and their solutions. Maybe you already saw a patient with desire or arousal, the problem, and you walk her through that, and she is in that group. She will be telling them this is that you are an expert. You came with so problem, and at the end, I'm okay. Group your patient, counsel them, make them feel they are not alone. And if it's the person with the partner, also counsel them. Tell them her problem is not the kind of problem that will lead to divorce. It's just it will just take some time. Maybe after some time you can check and see if the problem still persists, but I need your cooperation also. You counsel the couple together. Then encourage on open communication. Communication is vital in relationship, no matter what. And we women, we need to know how to communicate. Many women doesn't know how to say a word. And male are people that always want to be praised. They want to feel they are the owners of the house. They are the givers. So you need to know how to talk to them. For instance, you are not feeling what your man is doing. He keep touching, but you are not feeling the touch. Use a romantic way. Use a very good communication. You can tell him, my dear, I love the way we touch me, but I will love it if you struck me around so, please. If you can't talk to him directly, send him a text. I love the way you touch me, but I will love it more if you give me some kind of gentle stroke around so place, maybe around my breast, around my clit, around the area that you feel the touch, you feel more sensitive around that area. Give him some kind of text. At least you didn't say you don't want the touch. If you say you don't want the touch, at the end you may even don't even receive the one that you don't watch. So you have to be open in communication and also know how to communicate. Communicate very effectively. Communicate in a romantic way so that your partner will perceive it, and he will definitely give you the right thing that you want since you ask for it, and he will try as much as he can to see that he give you the best. You also need to teach and practice new approaches and behaviors. For instance, if the man agrees that he want to be part of the management, you ask him, I want to give you some assignment. These are the place so and place that when you touch a woman, the woman will feel more pleasure. She will scream for you. She will yearn for you. She will just keep praising him. And I want you from now to 1 week to practice with these new approaches. You ask him to go and practice with new approaches, and let's see in 1 to 2 weeks how this will work. So you encourage your partner to do that. If she doesn't have a partner and she's alone, she's just practicing with herself, teach her where and where to be touched. She will be touching it herself until she experiences that pleasure. Then there is way of vaginal steaming. Vaginal steaming is very important in female. You can steam with just warm water, or you can steam with some kind of herbs, provided the herbs are okay and are not harmful. The essence of the vaginal steaming is sometimes the Bartholin glands or the Schelling glands, they can be clogged. They don't release their lubrication. However, if you are steaming, it's just like the way we steam our nose if you're having catarrh. Maybe your nose is so blocked. Once you have some kind of steaming, you will feel the catarrh is rushing out and you are feeling okay. So just like the way you steam your under, you steam your vagina. Once you steam it, if the glands are clogged, they will start releasing the dirt inside it, and it will go back to its normal stage of secreting the lubrication for proper penetration and slippery vagina. Then there is the situation when the woman will complain of pain during intercourse may be due to vaginal dryness. So in this case, you don't have to ask them to stop having intercourse until her body is okay. No, you can use some kind of measures. You encourage them to do some kind of pleasurable touch using, and also to use some lubricants. There are a lot of lubricants in the market. They can be oil-based, water-based, or silicone-based. The oil-based are good. However, if you are using condom, you have to avoid them because they break the condom and they are easily stainable. They stain your clothes and they stain the bedsheet. The water-based are good. They are not staining. They are not staining. They are good. However, they easily dry. You need to keep applying even while you are while you are having the intercourse. You need to wait and apply again for you to continue having the lubrication. There is silicone base. The silicone base is the best recommended now because it's slippery. It's just like a natural lubricant. It's so slippery that it can sustain you no matter how long you go into intercourse. However, you have to put extra careful while having intercourse, especially in some couples that they like lighting candles around the mattress or around the bedside because it's inflammable. It can catch fire. So we have to be extra careful, but they are so jelly and they are similar to natural lubricant. They are better to use. There are a lot of them in the market. You can ask based on the description whether you want oil-based, you want water-based, or you want the silicone-based lubricant. So in the management, especially if there is some kind of problem with stress, so the woman need to relax herself, you to mobilize some kind of relaxation techniques like mindfulness or yoga and deep breathing exercise. The woman, you need to teach her whenever she is stressed, she take a deep breath and focus on exhalation for her to relax. She go into yoga classes for relaxation, for her to relax her mind and enjoy the sexual encounter. There is some kind of myofascial release. That is when there is some kind of trigger points in the vulva area or within the vagina. You find out that there are some kind of trigger points. You can use some kind of gentle manual release, manual technique like the myofascial release. You can massage the area. You can have a deep frictional massage around that area and it will release the trigger points. Then there are a lot of exercises that a woman will have to utilize in order to give some kind of stretch to the pelvic floor, especially in a situation where there is some kind of hypertonicity of the muscles. There is what we call the butterfly pose, where the woman will pose like a butterfly and give some kind of stretch in her pelvic area. Happy baby pose, brock pose, or lunges, a lot of them that will give some kind of stretches in your pelvic area. Then in case a woman is having some kind of issues, like she's diabetic, maybe she is diabetic, she's having some kind of cardiovascular issue, she is obese and others, she needs to have some kind of lifestyle modification. She needs to be placed on good diet. If you are knowledgeable about how to describe or prescribe good diet, then you prescribe good diet routine for her, or you refer her to nutritionist for that. Then for weight loss, you strategize a very weight loss plan for her based on her body and based on her needs. Then also engage her in proper aerobic exercises. There are some kind of pain relieving techniques or modalities that it can be used to relieve pain, especially in case of vaginismus or around or the vulvar pain or If there is vulvodynia or there is vaginismus, we can use all this, or in chronic pelvic pain to relieve pain. We can use cryotherapy. Cryotherapy, that is the way of using ice. You can have the ice crushed in a towel and placed directly to the vulvar area, or you can have a water bottle, ice water bottle with a straw, so that you can be pressing and gradually spraying the area with the ice water. It will give you a kind of sensation of pain relief around that area. We can use the transcutaneous electrical nerve stimulator. That is TENS. You can place the electrode around the inner thigh and around the pubic area. Depending on where the woman is having the pain, you can use the frequency between 75 to 100 Hz, and usually it will last for 20 to 30 minutes, and it will be good to be used twice daily until there is pain relief. Also, there are some kind of tools for relaxation. Relaxation, usually regarding the vaginismus or regarding the dyspareunia, that is painful intercourse. However, like dilators, vaginal dilators are used in a state of vaginismus. These dilators are so important because in a woman that had vaginismus, you cannot even place a finger around her vagina. She will scream with pain. So how can a partner go into her? She will not even allow that. So you need to use the vaginal dilator. You start with a smaller dilator. You teach the patient. Usually this can be done by the patient herself, because the patient will feel more relaxed if she is using it herself than you using it for her. You just need to guide her on how to use it and the best way to use it. She starts gently using the smaller vibrator. No, sorry, the smaller dilator. She starts with that dilator. She inserted, before inserting, she has to put it around her vulva area, press every part of her vulva until she reached around the vaginal opening. She kept it there outside the vagina until she had some kind of sensation of relaxation. Then she gradually inserted. However, before that, if she want to insert it into the vagina, she had to put some kind of lubricant, depending on the lubricant she want to use, either the water-based, the silicone, or the oil-based. Then once she keep it around the vagina, she left it there until she had some kind of relaxation, that the muscles are relaxing. She gradually inserted a little bit, not that far, just a little bit into the vagina, and also leave it there until she has some kind of relaxation again. Then she continue inserting little by little. This can be done for about 10 to 20 minutes until she finish, and can be performed either in the morning alone or can be performed morning and evening per day for like 5 to 7 days in a week. She will continue doing it until the best diameter of the dilator is reached. She can start with the smallest diameter. She can take like let's say 5 days, 10 days using the smaller diameter. Then gradually she moved to another dilator bigger than the other one. Then she start the same process of insertion, gradually, little by little, until she is okay and not feeling pain with that dilator. Then she move on with the other dilator and continue. However, we have to be very cautious here. You can introduce her to a bigger dilator that is bigger than her partner. And in that case, we are doing the wrong thing. Because there are bigger dilators that may be bigger than her partner's penis. And if you introduce her to that bigger dilator and she is okay and feeling good and sexual satisfaction with that bigger dilator, and she resumes sexual intercourse with her partner, and her partner's penis is not as big as the last dilator you use, so there is kind of problem. So you need to work with the patient based on her partner. And gradually, you ask her partner to come in and start as when you reach the size of her partner, you ask the partner to come in and start. or before you reach the size of the partner, you can ask the partner to start rubbing his penis, or for if she's single, to start rubbing her normal dildo around her vagina for appropriate sensation. Then we can also use vaginal wand. Vaginal wand are some kind of sexual toy. It's not toy per se, it's used for relieving trigger points. The woman will insert it into her vagina and be moving it cyclically or clockwise based on where she is feeling the pain. Then she circulates it there and move it until she is feeling some kind of relaxation. There is also what we call the vibrators. If you are not having vaginismus and you can, but the muscles are not relaxing very well, and you want to feel some kind of relaxation, you can use your vibrators. Their vibrators can help you have some kind of intense pleasure for orgasm to occur. Okay, we are also moving into pelvic floor muscle rehabilitation. There is rehabilitation for hypotonic and hypertonic pelvic floor muscle, depending on what your assessment outcome is. If the pelvic floor muscles are weak, so you need to strengthen the pelvic floor muscles. Strengthening of the pelvic floor muscle depends on the power of the pelvic floor muscles. If the power is just 0 and 1, you cannot ask your patient to start doing Kegel. You will just worsen the condition. By this time, you start with electrical stimulation and some biofeedback devices. You use electrical stimulation using vaginal electrode. The vaginal electrode, you apply some kind of lubricant and insert it into the vagina, and you use the stimulator to stimulate the muscle. This will help the muscle in activating the muscles. When the muscles, they are activated, and you can have some kind of movement in some kind of power in the muscles around two, like that, then you can initiate the Kegel exercise. So how to do Kegel exercise? There are a lot of people out there, social media, Kegel, everywhere Kegel, but how to do a correct Kegel exercise? This is so questioning, because once you see someone in social media, they will just ask you, this is how to do Kegel. They will just teach you breathing exercise because that is what they saw in the literature. They will just teach you breathing exercise and they say that is Kegel exercise. No, that is not Kegel. That is exercise that you can add for resistance while doing Kegel, the breathing exercise. So how to do Kegel exercise? Kegel exercise can be done. You first ask the patient to assume a comfortable position. Usually, the patient is better to assume a position like sitting, because if you are lying down, the gravity is assisting on you. The muscles will be very difficult to be picked. So you may ask the patient to have a comfortable sitting position, or you can even have some kind of roll, or you can rub your roll. You can roll your wrapper or your head tie and place it directly under your vagina, so that she can have some kind of sensation of that roll in her private area. Then you ask the patient, you give her the cue that she will understand. I want you to squeeze your pelvic floor. I want you to squeeze the thing that I place under your private area. I want you to squeeze it as if you are using your hands to pick it, but use your pelvic floor muscle to pick it. I want you to pick it or to squeeze it. Give her the cue that will be more understandable to her. At the beginning, she might not understand, but with gradual repetition, she will understand your cue. Ask her the correct Kegel is first the squeezing and later the lifting. She squeeze and lift the muscle in. That is the correct squeeze of pelvic floor. So once your patient mastered how to do the Kegel exercise, then you ask her to be doing it depending on what you as the clinician want. Maybe you ask her to be practicing like 20 times at one rule for 3 times in a day, then gradually you can increase it. And once the woman can master that squeezing and lifting, you can ask her to do it while lying, then let her while standing or while doing some kind of breathing exercise. And for better understanding, you can incorporate breathing exercise into doing the Kegel. You ask her to take a deep breath. Once she take the deep breath, once she is exhaling, that is breathing out, you ask her to squeeze. That will be more easier. You can also try and see. Once you take a deep breath and you want to release, that is the exhalation, you exhale through your lips gradually while squeezing your pelvic floor. That will give it a very good squeeze. So this is how you teach your Kegel exercise. Then there is Paula exercise. Paula exercise is a new technique where you can stimulate or strengthen the pelvic floor muscle indirectly, just the way we use the transverse abdominal muscles to contract the pelvic floor muscles. They are indirectly stimulating the pelvic floor muscle, just like activating the core muscles. Once you activate the core muscles, you are indirectly stimulating the pelvic floor muscle. Also, the Paula exercise is similar to that. However, in Paula exercise, you are using circular muscles of the body. Any circular muscle of the body, and especially according to the literature, the eye muscles, because the eye muscle, they take the shape similar to that of the muscles around the pelvic floor, the eye muscle. So once you contract the eye muscles, and you keep contracting gradually. There are different ways of contracting. Some you contract and relax without opening your eyes. Some you contract deeply and open your eye gradually. There are different ways of doing the Paula exercise, but the best one is you close your eyes while sitting, you relax and contract the eye muscles gradually. If you contract the eye muscles gradually and you hold for like 5 seconds, then you release gradually for like 3 seconds without opening your eyes. By doing so gradually, you will feel some kind of flicker or some kind of sensation in your pubic area. So by gradually doing that, your pelvic floor muscle will be stimulated and they will be strengthened indirectly. Just the way the core muscles activation are, you do some kind of core muscle activation exercise, different like the breathing exercise, the deep breath exercise for it to work with the Kegel exercise, because it's just like a cylindrical activity. In the front, we have the abdominal muscle. At the back, we have the lower back muscle. And also we have the diaphragmatic muscles around the chest. And at the bottom, we have the pelvic floor muscles. So once you activate any muscle, once you activate it, the other muscle will also be activated. And by doing so gradually, the pelvic floor muscle will be strengthening and you are rehabilitating your hypoactive pelvic floor muscles. Then we have the hyperactive pelvic floor muscle. That is, the pelvic floor muscles are not relaxing. They are not relaxing, they are squeezing. They are always tensing. And there is no good lubrication for proper sexual penetration. So in this case, you need to work on relaxing the pelvic floor. In this case, you have to work with the reverse Kegel. That is, for the reverse Kegel, that is, you do the opposite of the Kegel exercise. In this context, instead of focusing on exhalation, that is breathing out, you focus on inhalation. Once you focus on inhalation, once you take a deep breath in, you ask your patient, once you are taking a deep breath in, try and let go of your vagina as if you want to drop it out. You take a deep breath, try and open up as if you want to let go of your vagina. There are also some kind of reverse Kegel. They give the explanation that you can use a straw. You are blowing water. You are not using your abdominal muscle. You are just trying to blow water inside through a straw. While blowing that water, you keep relaxing your pelvic floor. You keep relaxing your pelvic floor. You are not engaging your abdominal muscles in this situation. So also you incorporate the relaxation. Also for relaxation, you also can incorporate the breathing exercise in this regard. There is vaginal steaming, just the way that I explained, also to unclog the Bartholin gland, the Scalene glands for better lubrication. The last stage in the management is to review the treatment process and the outcome. Maybe you spend like 10 sessions or 15 sessions with a woman, and you keep tracking your progress, and at the end, you sit with the woman and review her treatment as well as the treatment outcome. You remind the woman that you come to me complaining that you don't feel sensation, you have problem with lubrication, you have so kind of problem, any problem that she told you at the beginning, remind her with that problem. And now we are like into 10 session with you, or into session, depending on the session you did to her. So now I want us to review and see what remaining, or what are we going to do regarding the management. Maybe she said, now I'm okay, I'm feeling my husband, I'm feeling my partner, my body is responding very well, I'm so slippery during the activity, I'm so. So you track your treatment process and you have a good outcome. That's very good. And you decide whether you want to discharge the woman or you want to keep her and continue some kind of management depending on what remains in the process. However, you need to explain to her any pitfall, any other problem that she may experience in future. For now, you ask her to be so cautious regarding relationship. Maybe her problem is due to relationship. You ask her the way, you teach her the way she will talk to her husband. Even if he's wrong, you don't use wrong to correct wrong. You use right to correct wrong. You explain to her that you already taught her how to communicate effectively with the husband, not to just continue, not just to be talking to the husband anyhow. Even if he's wrong, you teach her the right way to talk to the person, and she's seeing some kind of improvement. Talk to her that she needs to continue with that strategy in order to avoid her problem if she doesn't want a kind of relapse in her life. Anything that you taught her that is continuous in nature, she needs to continue with that treatment, even if you discharge her, because if you stop that thing, the problem will relapse again. So in conclusion, I don't think, maybe I'm too far, I'm sorry. In conclusion, female sexual function is a normal process of experiencing pleasure from desire, arousal, orgasm, up to satisfaction. Female sexual dysfunction is any problem that may occur, either one or more, within the sexual function piece. Pelvic floor dysfunction involves biopsychosocial factors. It can be due to biological issues, it can be due to psychological issues, it can be due to social issues. Anything can lead to female sexual dysfunction. Assessment and management is through multidisciplinary care and mostly involve the biopsychosocial model. Thank you so much. And here are some references that will help in reading and further things. Thank you so much. Thank you so much.
Thank you so much, Ma. Thank you so much.
Thank you.
Thank you.
Doctor.
Thank you, Ma.
Thank you.
I believe there will be some reading materials which will be passed to the participants.
Sorry?
But we will have some reading materials from you,
Yes.
maybe to the participants.
Yes, there are some kind of materials. I will send them later, especially the last book that I posted in the references. It's a very good one. I will send it to them.
So that they can use the rest of the hours to study those books.
Yes.
Of the training. Yes.
Yes, especially the book has a lot of references using different researches that explain the problems regarding female sexual dysfunction. Because if I said I have to be writing it, it will take me many days before I finish making the slide, but I have the book I will share with everyone by God's grace.
Okay, thank you. So the questions now, the floor is open for questions and comments. I think we can't hear you.
We cannot hear. His voice is cracking.
Yes. I think you need to check your network. We can't hear you. You are not audible.
Are you hearing now, sir?
Yes, we are
we
hearing.
Please, ma, can you explain more about that polar exercise?
Okay, the polar exercise. Okay, you're welcome.
Yes, ma.
Yes, the polar exercise is a new trend of exercise that there are limited studies regarding polar exercise. The studies usually they utilize different kind of condition like stress incontinence, like pelvic floor dysfunction, that they said once you exercise any circular muscle of the body, the effect will go through to any other circular muscle that has dysfunction. So now the pelvic floor muscles are a form of circular muscles in the body. So any dysfunction in the pelvic floor muscle, it can be rectified using another good circular muscle in the body. And according to some research and the developer of the exercise, that is the Paula Garbok, she said exercising the eye muscles is more effective in activating pelvic floor muscles. So I tried it in my PhD research and it worked wonders in people with incontinence, with vesicovaginal fistula. We utilized the eye muscle exercise for like 12 weeks. They used to contract their eye muscles for like 7 seconds and relax for 5 seconds, or you contract for 5 seconds and relax for 3 seconds without opening their eyes. And by doing so gradually, it starts stimulating or activating the pelvic floor muscle, and the strength of the pelvic floor muscle start to improve and increase gradually. You can try with yourself. Maybe you can start today and tomorrow. By next tomorrow, you will start feeling the effect. However, if you have an intact pelvic floor, you can even feel the sensation instantly. Once you start contracting and opening your eye muscles, by doing some kind of repetition, you will start seeing your pelvic floor start picking and want to contract with you together. That is for the Paula exercise.
Thank you.
You're welcome there. So any other question? Hello?
Hello, I have a question.
Okay, ma.
Thank you very, very much for such insightful training.
Thank you, my
I'm
dear.
so sorry I joined late. Yes, I joined when you were talking about an outcome measure
Okay.
that you were trying to, I've forgotten the name now. I wanted to ask on perfect. I don't know if you talked on perfect.
Yes, I talk on it.
Okay, I don't know if you can
Yes,
just
you
briefly
did.
just do.
Yes.
I would have
I
missed
said
that. Yes.
maybe, okay. I talked
And
regarding
just
the perfect
yes,
curve.
if you can just talk about the perfect, how it's done,
Okay.
then how you use it as an outcome measure.
Okay, no
Yes.
problem. Thank you.
Thank you very much. Thank you.
Yes, the perfect scale is a scale that is an acronym where P
Yes.
stands for power, E stands
Yes.
for endurance, R stands for repetition, and F stands for fast movement, and ECT stands for every contraction time. For the power, you have to use another different scale to quantify the power. Maybe you can use our normal muscle grading, or you can use some kind of digital pelvic floor, the contraction scale to quantify the power, or you can use some kind of biofeedback device, maybe the perineometer. You can use it to know the power of the pelvic floor muscle. Maybe you can see, you measure, and there is some kind of flicker of movement. So she can squeeze, she can do something. You measure the power, she has like 3, the woman, like that means P equals to 3. Then you want to check for the endurance, that is the ability to hold. She hold the contraction. How able can she hold the contraction that she is having? You ask her to contract your fingers while inside. She contracted, you hold it, you count like 1, 2, 3, 4, then she release it. Or she cannot go beyond 4. You ask her to do it again, you want to take the average. You ask her 1, 2, 3, 4, 5, she release it again. Then you ask her to do it again. She take 1, 2, 3, 4. You do like 3 times. Then you take the average. Based on this explanation, maybe her endurance is 4, because at the beginning she did 4, she did 5, she did 4 again. So we can say the average maybe is 4 or 4 point something. That is for the endurance. Then for the repetition, how many number of repetition she can go for hold. You ask her, she continue holding 1, 2, 3, 4, 5, then she release 1. 1, 2, 3, 4, she release. Then gradually she reach to a place where she just do 1, 2, then she stop. That means her repetition is not more than 4 or not more than 5. So she cannot repeat more than 4 times. That endurance level cannot be repeated more than 4 times. That means her repetition is 4. Then regarding the past contraction, how many past contractions she can have? This past contraction is very important, because once there is sudden increase in abdominal pressure, that is when the past contraction is important. She can quickly hold her pelvic floor in order to prevent leakage of urine. How many past contractions she can do? You ask her, keep contracting, contract, relax, she do. Then maybe she leaves like 6, then she cannot bother to contract or relax. The muscle and tense are fatigued. That means her F is, let's say, 6, so she cannot go beyond that. Then every contraction time, that is the explanation I give you. You time every contraction for better recording. I hope you are okay with the explanation. Or you need me to say it again? Hello? Hello? Maybe she's not here.
She's there, maybe.
Okay.
Yes, I saw a question in the chat box.
Okay, so what?
How does female sexual dysfunction affect the individual physically?
Okay, physically, usually the woman may become so devastated that she cannot be in some like social gathering. She will feel the depression. She will feel a kind of depression. She is depressed that she cannot be presenting herself physically into some kind of social gathering, into the family. She is not having fun with her family because she is feeling that she is so down, she is breakdown, that she cannot continue her life the way she wants. That is the physical thing that affect her.
Okay, I'm ready for my question.
Okay, you're welcome.
Okay, thank you, Ma, for the explanation.
Okay, you're welcome.
In using perfect, do we use a pelvic floor? Do we divide that the vagina into 4 quadrants, or do we just insert our hand and just start to check? Do we go up? Do we have to check into the 4 quadrants, like dividing that part into 4? You have the left upper, the right upper, the lower upper, and the left lower. You don't divide for perfect.
No, we don't divide for puppet because
Okay, so it just
the
once.
P,
Okay.
yes, because the P that stand for power. You cannot just say the puppet cannot quantify the power. The power is just for you to use another skill, different from puppet, for you to quantify the power. You have to use another skill for you to quantify the power. That is the skill that I explained. Let me see if I
No,
can.
I understand. I understand. We use a modified,
Yes,
also
yes,
called
yes, that
modified
is it.
P.
Yes, yes.
What we've noticed from experience is
Okay.
that if you insert your hand,
Yes,
some portion sometimes will be
yes,
weaker than the other.
yes, that is it.
So
That is the,
if you
that,
yes.
okay, continue, sorry.
Yes. Sometimes when we insert our hand on the upper part and
Mm,
maybe the upper left part, it may be
yeah,
weak, while the
yes,
right upper part will be strong. When you
yes,
come lower, that's why I'm using the word, using the pelvic clock, trying to
yes,
divide into 4 quadrants. You
yes,
now discover that all the portions do not have the same power.
yes, that
So
is
that
it.
brings me to, yes, that brings me to my next question, because I heard when you were talking about hypersensitive, no. When the muscle is
Hypertension?
hypertonia and hypotonia.
Yes,
So I was thinking, for my own
okay,
little understanding, I may be
okay,
wrong. That's why I'm
okay,
here to learn. When we
okay,
get to that fast, when we are checking for fasts, and
yes,
the person can contract but cannot relax,
yes,
from what I learned, is indicative that the person may be having a hypertonicity, so they
yes,
cannot relax. Because I
yes,
know that you
yes,
mentioned that, yes.
yes,
Then,
yes,
now the rule is the rule now is, if you see a portion having like 2 or 3, another portion 1, the rule, according to what I was taught, that you will not stimulate because of that hypertonicity. You have to
yes,
try and do a relaxation exercise just like you prescribed. So I
yes,
just
that
want
is
to
it, ma.
confirm if it's correct. Yes.
Yes, that is it, ma. You cannot, if a female cannot relax her pelvic floor muscle, you cannot
Mm.
even try the stimulation, because
Yes.
you are further making the muscle more tense. You need to concentrate on relaxation. And regarding that, your question regarding one part will be relaxed and
Weak.
the other part will not
Other
be
week.
relaxed. That
Yeah.
is the two. That is weak pelvic floor muscle, because there is
Yes.
no
Yes.
circumferential hold. Once there is a
Mm-hmm.
circumferential hold, that is when the muscle is 3. But if
Okay.
there is no circumferential hold, maybe around 1, 2 o'clock, you feel the hold, then around 5, 6, there is no hold. That is
Mm.
absent of circumferential hold. At that time, the
Okay.
muscle, you just name it as 2.
Us too.
Yeah.
Okay.
Yes.
Okay.
Thank you.
Thank you. Thank you very, very much.
Thank you, ma.
So I want to have the last question. If a woman who is menopausal
Okay, ma.
is having a painful sex with her
Yes.
spouse,
Yes.
yes, she says foreplay is okay, the initial intercession is okay, but
Mm.
after a while, so let's assume that we divide it into 3: the entrance, the movement, the final part. She starts having a knife throbbing, like you actually, the man is as if the man is actually using knife
Yes.
into her vagina. So that
Yes.
stops her from, because I know you were talking about enjoyment. I love that scale. I would like to have, I know you talked about enjoyment, you talked about pain.
Yes.
I'm interested in understanding the physiology of what is happening and how she can be helped.
Yes. What
Then,
happened in this?
sorry, ma. So I will not forget the second one. Please,
Okay.
with the gel we are using, I'd like you
Yes.
to help me also to just highlight on that one as well after this sexual
Okay.
pain. I'm
Okay,
very grateful. Thank you.
regarding the penetration pain, usually the penetration pain is is due to spasm of the pelvic floor muscle. The spasm can be primary and it can be secondary, because once you insert the penis into the vagina and there is pain, that one too can be the primary, because it's at the beginning of the intercourse. However, in some women, it will come later. Maybe, just like you said, in menopausal women, due to that lack of estrogen in them, that little lubrication that she has at the beginning, the lubrication start to dry, and the dryness start from inside. So once there is that dryness, she will start having pain, and if the penetration also continue, and if the man is also removing and taking his penis back, that will add to more dryness and it will have more pain. That is regarding that situation is also a dyspareunia situation for that menopausal woman. Is dyspareunia due to lack of enough estrogen for lubrication, and the Bartholin glands are not releasing what they're supposed to release. And also the man is constantly removing his penis. Once there is constant removing of penis, it will lead to dryness also. Then the last question you said regarding the gel we are using. There are different kind of gel. There is oil-based gel. The oil-based gel is like the coconut oil, the olive oil, and related oils like that. They are so good. However, if you are using condom, they can break latex condom, and they can stain your clothes, they can stain the bed sheet. That's why many people, if they are using condom, they don't use the oil-based lubricant. There is also what is called the water-based lubricant. The water-based is very good, and you can use it even on the shower. You can use the water-based. The water-based is so good. However, some people said is, according to the literature, you need to keep applying it even during the sexual intercourse, because once you go into the intercourse, you rub the oil. No, you rub the water-based lubricant. After some kind of
It will dry up.
penetration, it will dry, and you need to
Add
put more.
again.
Yes. However, the silicone one is the best one because
Okay.
it's like the real jelly. It's jelly, just like the natural lubricant.
You know about KY gel?
Yes,
Is
the
that
KY gel is water-based, ma.
okay? No wonder.
Yes, KY
Yes.
gel is
Okay.
water-based. Yes,
Okay. Thank you.
yes.
Yes. Okay. So
Thank
the
you.
silicone
Sorry?
one is the best.
Yes, the silicone
The
one is
silicone
the
one you're
best,
talking
ma.
about is the best. Okay, so it's written on the body.
Yes, it's the
We will
best.
see it, silicone gel.
Yes,
Okay.
yes.
Okay.
You will see it, ma.
Okay.
It's written.
Okay.
There is
Silicone.
many kind of brand. I cannot say the brand now, but there. Once you go to a pharmaceutical company, you ask them regarding the brand you want. No, the base you want, whether the oil, the water, or the silicone base. There are many there.
Okay, but
Sorry?
concerning that this woman that is having penetration, from your explanation, is secondary. Concerning
Yes,
the
it is.
menopausal woman who is having sexual pain, the secondary part, how do we come in, both in the primary and the secondary? How do we come in as women's health physiotherapists?
Yes, we come in to regarding the use of this the prescription of the lubricant. You ask her to be using the lubricant.
Okay.
Don't allow herself to dry. And also, once they are into the intercourse, they shouldn't just concentrate on the penetration. They should also concentrate on some touches that will also keep stimulating the woman for more pleasure.
Okay. So you talked about that it may be due to spasm.
Yes,
the woman is already having, she's having slight urinary incontinence.
Okay.
So I was not thinking that maybe because the pelvic floor is weak, but now
Yes,
that she's not complaining, yes, she's now also complaining of that
but the
pain,
incontinence,
which is
but the
indicative of
incontinence,
like
sorry, ma, the incontinence
yes,
is what of incontinence. Maybe she's having some kind of urge or something. Or is it stress?
It's odd.
Yes,
It's
yes.
odd.
Since it's urge, since it's urge is due to the spasm of the pelvic floor muscle. That is the urge side, ma.
That's good. Thank you very much. So
You're
now
welcome.
we don't say it's weakness. We say it's hyperactive.
Yes.
Okay.
Yes, the urge is due to hyperactive of the pelvic floor muscles, ma.
You also said sometimes when she wants to poo, she has to like help herself to actually bring out the excreta.
Yes, that means so the pelvic floor muscles are not relaxing. Yes, they need to relax for you to poo very well. The pelvic floor muscle need to relax. You have to engage her in breathing exercise for relaxation very well.
Okay.
Yes.
Thank you very, very much. God bless you.
You're welcome, ma.
Thank you.
You're welcome, ma. Thank you.
I've
We are
learned a
all
lot.
learning.
Thank you.
Thank you so much. We are all learning, ma. Thank you. Okay. Any further question?
Yes, ma. Good afternoon, ma.
Good afternoon, my dear.
Okay, please, ma, can you throw more light on Kegel exercise?
Yes, ma, I can. Kegel
Thank
exercise.
you.
Yes, Kegel exercise is an exercise for strengthening the pelvic floor muscles. Once the pelvic floor muscles are weak, that is the hypotonic, then you need to strengthen them. And Kegel exercise have proven to be to have level 1 evidence. How to do Kegel differs. However, the best and the correct way of doing the Kegel is through giving good verbal cues to the patient and also knowing how to do the right squeeze and the right lift. You need to explain to the patient that your muscles are weak and I want you to learn how to strengthen those muscles. Just the way that I said at the beginning, you can have some kind of ball. You can roll some kind of ball and place it under the woman around her vagina so that the ball can be touching her private area, so she can be having some kind of sensation of that ball. You ask her, I want you to pick that ball as if you are using your hand to pick it, but now you are using your vagina or the pubic area to pick it. Ask her, she need to squeeze the muscles and lift them up. At the beginning, she might have it very difficult, but with gradual cue, okay, as if you want to stop the flow of urine, try and stop the flow of urine. Imagine you are urinating and you want to stop it. So once you squeeze that muscle, so you lift them up. That is the first squeeze is around the urethra. You squeeze around the urethra and you lift it up. Then you can incorporate the Kegel for better doing using the breathing exercise. You ask the patient to take a deep breath. Once she take a deep breath and while exhaling, then she use pulse lip to exhale gradually. While exhaling, then she pick the pelvic floor muscle. That will be best and the easiest way to do. Once you are exhaling and you are picking, because naturally, once you are exhaling, the pelvic floor muscle in their natural position, they will just go up. So they help you and you continue during exhalation. Then you squeeze and lift the muscles up. I hope you are okay, my dear.
Yes, ma. Thank you very much, ma.
Yeah, welcome, my dear. So any further question? Sorry, I'm so fast. We are just not even 1 o'clock and we finish. And I hope we learned something new from this message.
Yes, ma'am. It's okay.
Okay,
Yes,
thank
I
you.
have another question, or
Okay,
should I
ma'am.
say clearance? Yes. I
Okay,
don't know if you've heard of the combo exercise that you have to incorporate on supine lining, knee flex. You have to incorporate the tightening of the adductors and the tilting of the pelvis, and then the tightening of the abdominal muscles.
yes,
That
yes,
research was carried out by Dr. Ojuku and
yes,
some others, and they discovered that it got better result than just doing Kegels alone.
yes, ma. Yes, ma. I learned about it, and that one you have to learn the better way of doing the Kegel. Those one are some kind of resistance to Kegel. Just the way you are doing some kind of strengthening exercise, you want to be
Yes, yes.
increasing resistance. So that contraction, that change of position, that is that you said are kind of adding resistance to the body for better contraction.
Okay.
Okay, do you understand?
No.
Because once you want to strengthen, let's say you want to strengthen your arm, you start with
Okay.
2 kg
It's true.
weight.
Yeah.
Yes. Then
Okay.
gradually you are not feeling that 2 kg. You take it to 5
Increase.
kg. Yes. Then later you
Okay.
take it to 10 kg. So that is
So we say
once you
like
learn the
progressive
proper way.
exercise.
Yes. That
Progressive. Okay.
yes, that is the progression way of doing Kegel. You keep
Okay.
loading the body with many things and you keep contracting those muscles. So the muscle I keep loading for better resistance. Yes.
Okay. I see. Okay, makes sense now.
Okay,
You
thank
talked
you.
about reverse Kegels. Please, can
Kegel,
you go
yes.
back to it? I didn't get
Yes.
it, please.
Okay, the reverse Kegel is usually the reverse way of doing the normal Kegel. You concentrate for the normal Kegel, you concentrate on expression. But in reverse Kegel, you concentrate on inspiration. So in this context, you ask the patient to relax and take a deep breath. While taking a deep breath, she lets go as if she want to drop her vagina. You ask her, I want you to let go, or you want to let go the muscle that is holding your vagina. Once she is taking a deep breath, that is the reverse Kegel. It's a gentle pelvic floor relaxation exercise. Instead of tightening, you let go. That is just the reverse Kegel. For Kegel, you tighten and lift. But for this one, you let it go and relax. That is
Okay, that's
just
for hypertonicity.
yes, that is for
When you have
hypertonic.
spasm.
Yes,
Okay.
yes.
Okay, which other exercise? I know you were talking about a child pose.
Yes.
Child pose, is it part of relaxation?
No, so they are part for
Yes.
so they are part for stretching the pelvic floor muscles. They are also the relaxation by C, because if the pelvic floor muscles are tight, you want to stretch them, then you need to do some kind of pause that will help in stretching the pelvic floor muscles.
I've forgotten what they call that one. Is the one you have to kneel and bend down? Forgotten the name now. Is that one included too? Where you bend your knee, like the Muslim prayers pattern? You have to bend your knee.
That is the happy baby pose, right?
No. Happy baby pose is the supine with holding legs, swinging
one?
for one other. The other one is like you want to pray, like a Muslim wants to pray, but instead of
the cat and camel.
No. This one is kneel,
Sorry,
body
I
down.
think it's cobra. I think it's cobra pose they're trying to describe.
No, cobra pose. No, cobra pose. You stand. You lift your trunk. This like a Muslim that is praying. You know, when you kneel down, your head will down. This time around, your hand will now follow, and you will now be curved and stretched out in that manner. Forgotten the name. I think I will look for the name. Yeah.
Sorry, I can't remember it. Oh, sorry.
Okay, so child pose. Okay.
Yes.
So now, what you are saying is that if we have a patient that has a spastic pelvic floor muscle, we should do stretching for them.
Yes.
We won't use tense, we won't stimulate because already tense there. We should give exercises that will cause relaxation, like this reverse Kegel.
Yes.
I've learned
And
this
some
one
kind
now.
of stretches, yes.
Yes, I've written the stretches. Okay. But if it's for a weak pelvic floor muscle, let's say 2 and below.
Yes.
I'm hearing that some people do for 3 now. I don't know the school of thought. I thought when
Which
the power
3?
is power 3 for a week, they said if the muscle is still weak, some people will still stimulate. I just feel that may not be right.
So to be sincere, this is not a good practice. However, in case of you want to add to biofeedback, you can use it for the woman to understand the muscle, then you can withdraw it.
Okay, for biofeedback.
Yes,
but for weak muscle, we stimulate 0 to 2 at least.
Yes.
So,
you can stimulate.
Yes, I didn't quite understand that when you were trying to check for power. I know I learned something today that you talked about circumferential. Let me see where I wrote it. Circumferential hold. So I insert my hand, and the first command I give, if we are using Oxford grading, I think it's or let's use what you taught. I insert my hand and I tell the woman, squeeze my hand.
Yes.
And she can't squeeze, but I can feel like there is a slight movement.
That is flicker.
Yes, flicker. That's supposed to be like 1.
Yes.
Then if I now say squeeze, and I can feel a little squeeze.
From some angles, yes.
Yes, from not all around. Then
yes,
that is
later
true. I can see that she's trying to lift my finger up.
Yes. That is true.
Because I didn't really get that scale, because that was when I came in. I didn't understand that scale very well.
Yes, that is true.
Okay.
Yes, that is true. And once there is
so when we don't have all the circumference, let's just say the whole of the group of muscles holding together, it will now be what did you call it? It's not a circumferential hold, uncircumferential hold.
Yes.
But if it's a circumferential hold, it's 3+.
Yes, that is 3+.
But uncircumferential hold will be like 2.
Yes, like 2. And if there is a compression hold with good lift also, however, with conscious effort, that is 4.
Okay.
Yes.
Conscious effort. That person is making a conscious effort to lift.
Yes, that is 4.
Okay. Thank you very much.
Thank you, my
We're
dear.
waiting for your materials so that we can. I hope you can get your contacts with our women's health. I'd like to get your contacts.
Yes, ma.
I'm in
You
River
are not in
State.
our
My name is
group?
Dr. Blessing.
Yeah,
No, I
okay,
don't think so.
Okay, you are
I
not
don't.
in our group?
No, I don't think so.
Okay,
I should
ma.
be added. Please,
Okay.
someone should
Okay,
add
Dr.
me.
Samani will give you my phone. Bye-bye.
Okay, I don't know
Okay.
who is Dr. Samani. I only know Hafiz, actually. I don't know if Hafiz is
Maybe
here.
he will share it.
Should I drop my
To the
contact?
group.
I'll
Yeah.
send you the number. No problem.
Oh, thank you very much. Thank you. Thank you.
Thank you, my
Okay,
dear.
ma. Okay,
Thank you.
good afternoon, ma. Ma, let's
Good afternoon.
ma, I want you to share more light on the reverse Kegel exercise.
The reverse Kegel?
Yes, ma.
Okay. The reverse
Thank
Kegel,
you.
just the way as explained it to the other person, is a way of relaxing the pelvic floor muscle. It's a reverse way of doing the Kegel. In Kegel exercise, we concentrate on contracting, and while we put or we incorporate the breathing exercise, we concentrate on exhalation. However, in reverse Kegel, we concentrate on inhalation and lengthening of the pelvic floor. You ask the patient to take a deep breath. While taking the deep breath, you ask the patient to feel as if she is letting go of her vagina or the surrounding area. She wants to release it down. That is the reverse Kegel.
Okay, I've got it. Thank you, ma. Thank you very
Thank you,
much.
my dear.
You're welcome, ma. Thank you.
Thank you. Any further question?
Okay, ma, I just want you to thank you for the lecture. It was very
Thank you.
clear and straight to the
Thank you.
point. I
Thank
just
you.
want you to throw light on this electrical muscle stimulation to the pelvic floor muscle. I know we have vaginal electrode and also we have
Yes.
this electrode pad that we use. When it
Yes.
comes to women health and
Mhm.
situations like this, when do we
Yes.
use which? And I also want you to throw light on in terms of placing the electrode when we are using the pads. I just want to pick one or two there. Thank you, ma.
Okay. In case of using electrode in stimulating the pelvic floor muscle, just the way as I said, it depends on the power of the pelvic floor muscle. From 0 to 2, that is the appropriate way of stimulating the muscles. And in this case, we use the vaginal electrode directly inserted into the vagina. We use the electrode directly inserted into the vagina. However, you can use the pad, but not for that purpose. Usually is for another purpose, not directly stimulating the pelvic floor muscle. Maybe if the female is having some kind of pain and you want to use stimulation, the electrical stimulation for pain relief, or you want to use the TENS for pain relief or others, you can, if she has some kind of pelvic pain, you can place the electrode around the pubic area and inside and the inner thigh. That is for like a pubic pain around the pubic symphysis and other things. Or if she has pain around her coccyx, you can place the electrode around the coccygeal area and the ischial vertebrae. That is for that purpose.
Okay, ma, thank you so much. The reason why I
You're
brought it,
welcome.
I
You're
currently manage a
welcome.
woman with a systole grade 3. And
Sorry?
I say currently I manage a woman with is it systole?
Sister, okay, that
Yeah,
is from a
systole.
prolapse.
Yeah, yeah, grade 3. And
Yeah,
then
okay.
during the time of his examination and assessment, it was very difficult to actually assess the muscles because of the grade. That is the bladder almost at that.
Yes,
So
usually.
because
Yes,
we
usually in that situation, the electrode cannot even go into the vagina because
exactly.
because the protrusion is beyond the hymen.
Yes, ma'am.
It's outside. It's visible, so you cannot insert the electrode in that case. What works better around is the pain relieving modality and some kind of exercise that will eliminate gravity activity. Usually, you engage the patient in lifting her lower limbs up so that the bulge will go back down and sink in.
Okay.
Thank
Okay,
you.
thank you.
Please take that again. That last part. Please take that last part again. The last part.
Okay, the last part that I said.
Hello, ma. Please take that last part about the bulge.
Yes, I said. Yes, I said
the
once
bulge will go in. I didn't get
yes,
that.
yes. You engage the woman in lifting her lower limbs above her chest level, so that once there is that pressure, then it will assist the protrusion in going back into the vaginal orifice, and gradually you engage her into some exercises.
How do you do that? You say you lift her lower limbs up.
Yes.
Is she going to be on supine lining or?
Yes.
I don't get.
She lies spine, then you can have maybe like a window edge to she place her leg, or if you have the gym ball, you can place the leg. Yes.
Okay, gym ball.
On a gym ball, yes. You can place the legs on gym balls. Yes.
Okay. It's when you now place the leg, you now start doing those exercises.
Yes,
Why is there?
Yes.
Okay, if the bulge is already out, that's already like I don't know how out it is, because I know that if it is total descent, then it's stage 4 surgery.
That is stage 4. He said like stage 3. In that case,
stage
you
3.
just
Okay, you are seeing it. Yeah.
Yes.
Okay.
In
So
that
what
case,
do we do? Yeah.
Yes, we usually have a limited rule once the protrusion is outside, but in order to prevent further descent, you encourage those position and also the care girl in that position, and you report her to the gynae for further management.
Oh, that's stage 3.
Yes, because
She has to go
the
to
protrusion
gynae.
is. Yes, you have to refer her to gynae for further management, and you have to work on preventing further descent, because it can go to level 4.
Okay. So you say we don't use vaginal electrode for that?
Yes, it will not even go inside, ma.
But the patient you are managing, he did though. Unless
for stage
I have
3,
to pay attention on Monday. Yes. We
okay.
could just we see it's a teacher. She said when she was young, when she used to give birth, that I'm Igbo, they used to tie the abdomen very tight. Okay. So that she just noticed. But I went to give a talk, and she my assistant assessed
that
her,
would be
and
a
we brought
very
her to the
good one.
hospital.
Yes, that would be a very
I
good
will pay
one.
attention on Monday, and
no, ma, that would be a very good one. Once you can take it back and the electrode can go in, then you can go with the stimulation. Yes.
Okay.
Yes, that would be a very good one.
Okay. So another question I have for prolapse, like when you are examining,
okay, ma,
how do you know that this is uterus? How do you know that this is bladder? How do you know which is which of the organs?
Ma, depending on the angle or the direction of the vaginal wall where the protrusion is coming. Yes.
Okay.
Because if the protrusion is from the anterior part, that is the cystosol.
That's bladder.
Yes, that is from the bladder. If
you said it's from what? What angle is that? Frontal?
That is the anterior side. That is the anterior side,
yes.
the front. Yes, the front side, the upper part. That is from the bladder. Yes, but for the protrusion that is more posteriorly, that is the rectosol. And if the protrusion is more centrally, but
uterus.
Yes. So that is the uterus, and it's usually the one that if you push it back, it will go back. Yes.
It will go.
Yes.
Okay. Thank you very much. This has been very educative. Yeah. Thank you.
So, any further question? Okay, my dear.
Yeah, I know we are talking about female here, but what if it's the man now that is having this flow?
Yes, ma. By God's grace, our next presentation will be on male sexual dysfunction.
There is no how do you not stimulate?
Sorry?
How do you not do the stimulation for a male?
Stimulation for men.
For female now we have vagina element.
Yes, for men we have the rectal erectrode. We
Okay,
usually
there's
use the
still one that
rectal
will enter
electrode.
there.
We usually use the rectal electrode, not electrode that can enter that place.
Okay, not the pad, not the element.
Yes.
There's
We
a special
usually
one.
use the rectal electrode for
Yes,
stimulation.
yes.
Mhm.
Okay, so in the absence of that element, we can't use the pad at
No,
all.
we can use the patch one. We can use it depending
So
on
how do
where
you
you want
place
to.
it for the male?
For the male, depending on the condition, if it is for the erectile dysfunction, you place it around the pubic area and the inner thigh, just the way that I said it, because they are all the best for the erectile dysfunction. Our next presentation will be on male sexual dysfunction, and by God's grace, we will give more explanation there.
Okay.
Thank
So
you.
how do we get the electrode? Do we get it?
Which one? The
The
vagina?
electrode for the male. No, for the male.
No, it's the same electrode, my dear.
Okay, but we were placing around the perineum, so that's wrong.
No, it's not wrong. That's why
I
I
heard you
said
talking about
depending
the
on.
inner thigh.
Yes, you can place it around the inner thigh, you can place it around the pubic area, but depending on where
We
you.
what we do is we place beneath the penis, that's the perineum, before the anus, that side.
Yes,
Then we
yes,
place on the pubic side. Then
yes.
we also go and place at the dimples, and we place at the inner thigh. So please correct me. Let it
No,
not be that.
that is the right one. They are all
Okay.
right, but depending on the muscle
Okay.
you want to stimulate, that is the
Okay.
essence. For that,
Okay.
the placing around the perineum, you are targeting the ischial cavernosa muscle, and the
Yes.
pubic area, you are targeting the cavernosas. That is
Okay.
the crossfire technique for that muscle, and they are very good for erectile dysfunction, this combination.
Please take what you said again. Don't be offended, please.
No problem, ma. I said
We're talking about, yes. If we
if you
place
place the
placementship.
electrode, if you place the electrode around the perineum and around and around the pubic area, around the base of the penis, you are targeting the cavernosa muscles, the ischial cavernosa and the bulbo cavernosa. That they are the building block for proper erection.
Okay.
Yes. So we will discuss more by God's grace in male sexual dysfunction.
I hope yours is coming next. When?
Yes, by God's grace, depending on how they schedule it.
Oh, okay. Thank you very, very much.
Yeah, welcome,
Thank
my
you.
dear.
I'm so
Thank
blessed. Thank you. Learned
you,
a
ma.
lot. Thank
Thank
you.
you, ma. Thank you. Thank you, everyone.
Okay, thank you so much, Doctor, for the presentation.
Thank
And
you.
it has generated a lot of questions, almost 1 hour of interaction, which is
Yes,
very good work.
that is the better way, because we
Yeah.
learn when there is more interaction.
Yes.
Yeah.
So thank you so much, and we will discuss to see how we can schedule the male aspect.
Inshallah. Inshallah.
Thank you so much, and thanks to everyone for participating. We'll send the
Thank
book
you.
for that study. Thank you all.
Okay. Thank you, ma. Thank
Thank
you,
you,
ma.
everyone. Thank you, everyone, and God bless you. Bye-bye.
Yes, bye. Thank you, ma.
Bye.
You're welcome.
Thank you so
Bye-bye.
much, ma.
Thank you.
Our
Bye.
beautiful lecture.
Thank you so much. Bye-bye.
Bye.
Yeah.
Thank you, ma. Bye.
Bye, my dear. Thank you.
Thank you very much, ma.
Thank you. Bye, everyone.
Bye.